Welcome to a presentation on subgrouping low back pain. I'm Daniell Pennacchia, and this is presenting in part of my MSc in Manual Therapy at the University of Nottingham. The aims of the presentation are to present the rationale for subgrouping, in particular subgrouping by using the risk of developing a poor prognosis, to evaluate if tools that subgroup by risk are effective, and to consider the clinical implications of these findings. Let's begin by looking at some familiar stats. I think it's fair to say that low back pain is a well-established health, social and economic burden. According to the Global Burden of Disease study, published in 2010, low back pain is the #1 world health problem associated with years lived with a disability. In the UK, between 6 and 9% of people consult their GP for low back pain each year, accounting for 5 million GP consultations annually. The majority will experience a transitive episode, however 50 to 75% will still have disabling symptoms wander on. In the UK, annual total costs attributable to low back pain have been estimated at a colossal £12.3 billion. So why subgroup? Despite a number of high-quality randomised control trials in recent years, the fundamental question about which patients will respond best to which intervention remains unanswered. This current situation may in part answer why low back pain exists as the #1 world health problem. Best practice guidelines recommend grouping patients broadly into one of 3 groups. Serious spinal pathology and nerve root pathology make up an estimated 7 to 10% of the population, with non-specific low back pain making up the significant remainder. Within these broad categories, serious spinal pathology and nerve root pathology have often clearly defined pathways requiring ongoing medical or surgical intervention. However, the management of non-specific low back pain presents greater difficulties for primary care practitioners and physiotherapists, and this is likely due to the amount of heterogeneity within the non-specific low back pain group. Therefore, treatment for these patients should not be seen as homogeneous. Let's think about randomised control trials. One of the main aspects that adds rigour when comparing groups is trying to increase homogeneity within them. This can be achieved by considering baseline characteristics or by recruiting participants with strict inclusion and exclusion criteria. If heterogeneity is not accounted for in research, overall treatment effects seen at the group level may mask the reality that some patients benefit substantially from certain interventions and others do not. But it is also important to consider that the homogenised groups replicate patients in the real clinical environment, so that the generalisability of results is realistic. The arguments against subgrouping suggest that many subgrouping strategies have been based on unproven theories, are poorly validated, or have not been replicated. It has been shown that there is little consensus between clinicians regarding the signs and symptoms that identify non-specific low back pain subgroups. Therefore, if a subgrouping approach bases their treatment selection on causal mechanisms, there is potential for the course of low back pain to run differently over time within a given subgroup. What benefits does subgrouping offer to the patient? If we assimilate research to the clinical environment, we see that reducing unwarranted treatment variability typically leads to better patient outcomes. If the capacity existed to identify low back patients at risk of poor recovery early in the clinical course of the condition, appropriate intervention could influence outcomes. If prognosis can be more accurately identified, we might be able to manage patient expectation better, minimising anticipated outcomes and thus reducing patient frustration. Subgrouping takes on many forms. In order to better manage non-specific low back pain, subgrouping offers a range of approaches including treatment-based classification, pathoanatomical or causal mechanisms, movement dysfunction or impairment, and risk. The idea of risk has become more prominent recently, and this will now be explored in more detail. The goal has been to recognise the patients that are at high risk to proceed from an acute low back pain episode to more persistent pain and disability. Using epidemiological evidence to identify factors related to general prognosis is important when understanding risk. In 2008, Kent and Keating systematically reviewed the factors that predicted poor recovery from recent onset of non-specific low back pain. They found uncertainty around which factors are associated with particular outcomes, the strength of the associations, and the extent of confounding between prognostic factors. Despite this, in general, research suggests that psychosocial factors are amongst the most important epidemiological factors that predict risk. However, there is evidence to suggest that clinicians are inconsistent at applying assessment knowledge of psychosocial factors in their treatment approach, and in particular struggle to know at what point to specifically seek to address them. Evidence-based guidelines for non-specific low back pain in primary care support the consideration of prognostic clinical indicators, and subsequently tools subgrouping based on the risk of poor prognosis have been devised to reflect the increased understanding of the role that psychosocial factors exert over low back pain outcome and the clinician's reduced ability to recognise when to address them. Tools that use risk. A key point here is that without the aid of screening tools, clinicians do not seem able to accurately identify patients' prognosis. This makes a strong case for the introduction of formal screening tools. Two tools using the risk of poor prognosis to subgroup have gained prominence: the Cerebromusculoskeletal Pain Questionnaire, the OMPQ, and more recently the Start-Back Screening tool. Both are self-rating tools that ask questions predominantly within psychosocial domains and are used to predict the risk of long-term disability. Are they effective? Before we look at their effectiveness, let's look at their validity, an important characteristic of health measurement tools. In a systematic review, the OMPQ was found to have moderate predictive validity in identifying patients at risk of developing chronic pain, disability, or taking long-term sick leave. The Start-Back Screening tool is also able to predict changes in pain severity, disability, pain catastrophizing, and fear of movement when compared with questionnaires that individually measure these domains. The OMPQ and the Start-Back Screening tool have also been shown to have excellent correlation with each other. The Start-Back Screening tool has demonstrated poor inter-rater agreement between clinical experts and tool allocation to low back pain subgroups. Current rate of care for agreement between the tool and experts in subgroup allocation was 0.22 with a 95% confidence interval of 0.02 to 0.42, which inferred fair agreement. However, the confidence interval was relatively large, suggesting the agreement could in fact be much worse. In the only study of effectiveness, a recent randomised clinical trial found that the use of the Start-Back Screening tool combined with matched treatment pathways significantly improved patient outcomes compared with current best practice, whilst demonstrating cost-effectiveness across all subgroups. However, despite the overall benefit, there was no difference in the high-risk group that had received a psychological component to their physiotherapy sessions at 1 year on. The Start-Back Screening tool was not originally developed to be a robust clinical prediction rule and has been shown to have a high false negative rate. Therefore, many of the low-risk group may still be at risk of having a poor outcome. It is therefore essential that clinical judgment be used alongside this tool. Considerations in clinical practice. Because prognostic associations are inconsistently reproduced across studies and predictive models, these are not readily interpretable by clinicians. And given the volume of subgrouping strategies that exist, it is not surprising clinicians aren't sure which subgrouping method to use. There is still a big emphasis in physiotherapy, and particularly physiotherapy education, to select a diagnosis or prognosis based on pathoanatomical or causal mechanisms. Therefore, using other strategies might present with resistance. Overall, there is no consistent evidence that we are more effective at treating persistent low back pain. This situation in part might be explained by the lack of agreement of an effective subgrouping strategy for patients with low back pain. So to conclude, the consensus seems to be that subgrouping is beneficial, but trying to achieve the best method of subgrouping is difficult. Subgrouping by risk of poor prognosis has demonstrated some early signs that it could be effective, but can we ever accept one model of subgrouping? If you'd like this, read more at my blog, Pennacchia@wordpress.com, or You can follow me on Twitter at Pennacchia.